joining us for the webinar New Paradigms in Lung Cancer. We apologize for the delay, and now I'll hand it over to our program director, Dr. S.H. Advani, Senior Medical Oncologist from Mumbai, to please give the opening remark.
Yeah, good evening. Sorry, I had some problem in connection. But today we are really meeting together to discuss an important area where the whole landscape of the treatment has undergone revolution, right from the diagnosis to the therapeutics. The disease which was considered a single disease, like lung cancer, today can be divided into many types, depending upon the particular mutation which is present in such a situation. Not only that the classification has changed, but also the treatment has undergone rapid evolution. With the respect that today is not only chemotherapy, but targeted therapy based on the particular mutation. And therefore, targeted therapy today has become the first line of treatment whenever the mutation is present or demonstrated. Of course, the chemotherapy and now the new approaches like immunotherapy has also come up in a big way. And therefore, today we are really going to discuss about the way we are nowadays having a new insight and with a new paradigm in the lung cancer treatment. And all the experts are here today to show us and enlighten us on the subject. So with this, I would give the mic to my colleague to take care, Dr. J.P. Agarwal, who is a radiation oncologist from Tata Memorial Hospital. He is my colleague for a long time, from almost 30 years or so. And now he is of course, the chief of radiotherapy department at Tata Memorial Hospital. Dr. J.P. Agarwal, please.
Good evening, sir. The most optimistic guru, in the oncology science. And I really salute him for that. So the optimism brings us challenges. If I see yesterday's JAMA oncology paper with the COVID burden of with the lung cancer burden of 10 years, probably lung cancer still remains one of the largest killer. So we have a lot to work. And definitely these new paradigms will make a difference. And I will request our speakers to work on this, especially Arathi, to speak on the screening of early diagnosis in lung cancer with low dose CTs and low CT scan. Arathi, the stage is all yours.
Good evening, everybody, respected Advani sir and all the faculty members. I'm Dr. Arathi Nair, consultant pulmonologist of Smitha Hospital, Thodupuzha. I'm here to speak about early screening of lung cancer using low CT. Can you change the slide? Okay. So I'll just briefly explain what is a low dose CT. It's in simple words. It's now a new form of CT scan recommended for lung cancer screening, early diagnosis of lung cancer. That is, continuously it rotates in a spiral motion and takes several X-rays of the lungs. And it gives a very detailed study of the lungs, which is capable of seeing very small cancers in its very early stage compared to traditional chest X-rays or conventional CT scans. And it also takes much less time. Slide, please. So here I would like to just briefly mention about a study that was conducted in the US in the 2000s. It is a national lung screening trial. More than 50,000 patients were screened, both men and women, based on a particular screening criteria using this low dose CT scan. And there was almost 15 to 20% reduction in the mortality because of lung cancer, because of the early diagnosis with the help of the low dose CT scan. And in this study, screening was annually done for 3 consecutive years using low dose CT. Along with this, there are so many other trials which I will mention in another table. Slide, please. This is a diagram that shows that is the advantages, that was the benefits that were seen in this national screening lung screening trials. The case detected was more compared to traditional chest X-rays using low-dose CT scan. More cancer patients were detected, and the mortality rate, almost 20% of reduction in mortality was seen using low-dose CT scan. But in when traditional chest X-rays were used, which was a control, less number of cases were detected and more number of deaths were also seen because of the late diagnosis. Slide, please. So this is a table that briefly explains the various studies that were conducted based on this low-dose CT scan. We were used as a tool for early screening of lung cancer. The first one is, as I already said, it is a national lung screening trial. The group was low-dose CT versus chest X-ray, and more than 50,000 patients were screened, both female and men. And the eligibility criteria was 55 to 74 years of current or former smokers with more than 30 pack years who has stopped smoking within 15 years of age. And the screening was done annually for 3 years, and the mortality rate was reduced by almost 20%. Other studies are the detection and screening of early lung cancer by novel imaging technology, then the Danish lung cancer screening trial, and the multicentric Italian lung detection. All these studies briefly explains that the age group was almost between 50 to 80 years who had at least 20 years of pack years of smoking or who are current smokers, and the outcome was there was a reduction in the mortality rate in almost all the studies. Change the slide, please. But one disadvantage of this study, especially the national lung screening trial, was that there was so much of false positivity rate. That is, nodules which were not significant, which were benign, or other cases like abscess or tuberculosis were misdiagnosed and cancer, and the patient was subjected to so much invasive studies and more conventional CTs and radiation exposure. So it was the false positivity rate was more seen in the national lung screening trial and least in the MILD and Nelson study. This was because in those studies there was an intermediate group. That means in the annual screening, when it was found that the nodule was not significantly increasing in size or there was no changes in the texture of the nodule, those patients were moved out from the screening trial. Only those patients where the nodule was significantly increasing in size were subjected to further studies. So the false positivity rate were less in those studies, but in NLST studies, almost every patient who had a nodule were subjected to further investigation. So false positivity rate was much higher. That was a main disadvantage of that study. Next slide, please. So it was not so convincing because it screened many at low risk and over-referred nodules to clinicians, so that were all benign or some other conditions, and there was no fixed workup strategy, and higher level of investigations and surgery like CT biopsies, bronchoscopies, thoracoscopies were done for these benign lesions, and the better technologies were not used, and the screening was stopped after 3 rounds. That is, for 3 years annual CT was done and then stopped. Further workup was not done. Next slide, please. So who requests screening? So now the topic is mainly about this early diagnosis using the screening. So who requests is all the smokers, current smokers or previous smokers between the age of 55 to 80 years, previous smokers at least of 20 pack years or more, and who has stopped within the past 15 years should be subjected for screening. There are people who are not smokers but who had exposure to carcinogenic agents like radon, asbestos, silicose, etc. People who are having family history of lung cancer, and people who are having chronic lung diseases like COPD or interstitial lung disease. Next slide, please. So what else should the patient receive? When we do a screening, the only aim is not just early diagnosis of lung cancer, but it should be also a part of counseling of the patient also. That means the patient should be counseled what are the dangers that he or she can face because of smoking. So even though if the patient is screened to be healthy, or if the patient is not having any lung lesions or nodules, a counseling should also be given to the patient along with the screening, that you have to quit smoking at least by now, because now you are healthy, but in future you can develop such diseases which is like COPD or ILD or cancer. So you have to stop smoking as soon as possible. And also before screening, the screening using this low dose CT has some benefits and also harms. So that should be well explained to the patient so that future some problems can be avoided. Next slide, please. So what are the benefits of this early screening using a low-dose CT? So we have already said a low-dose CT is very capable of finding very small lesions that cannot be seen in a traditional chest X-ray. So diagnosis of lung cancer can be done in its most earliest and is treatable stage. So it will be a very small lesion and metastasis would not have occurred. So in that stage, it is usually very easy to treat lung cancer. And so hence, and since it is diagnosed in a very early stage, the number of deaths due to lung cancer can also be reduced. As previously explained in that trial, the National Lung Screening Trial, almost 20% reduction was seen. So that is also a very big advantage. Then this low dose CT is comparatively a fast procedure compared to conventional CT, and this breath holding is usually a problem faced, especially in aged people in conventional CT, and that problem is not seen in low dose CT. And it's obviously a painless and a non-invasive procedure, and it uses less than 90% less ionizing radiation is seen in low-dose CT scan than a conventional CT scan. So it is believed it causes less radiation harm compared to a conventional. So see, these are the benefits of screening used using a low-dose CT. But there are also certain harms that I've already said, that there are some false positivity rates were seen in this National Lung Screening Trial. So next slide is about the harms. Next slide, please. Even if we diagnose a patient early, not all cancers can be cured. So some patients might die in spite of treatment. So we can't assure the patient that, yes, we have diagnosed your cancer in a very early stage, so you won't die. That we can't explain. Sometimes the patient can die. Then some cancers might not be diagnosed. That is, some cases false negative results were also seen. Then other misdiagnosed, as that is false positivity. As I said, there was almost 21 to 23% of false positivity in that trial. That is, most of the benign lesions, they were subjected into so much invasive procedures, and later it turned out to be a benign lesion or some other infective condition. It was not lung cancer. So false positive rates were very high in because of the screening using this low-dose CT. Then sometimes just CT scan, that a low-dose CT can say something that you have a nodule or there is a small lesion or a calcified lesion. So it just a CT can't diagnose a cancer. It requires invasive procedures, obviously, like a biopsy or a tumor resection or a thoracoscopy, bronchoscopy. Some invasive procedure is mandatory to confirm the diagnosis that it is a cancer and also to classify the type of lung cancer. So just a low-dose CT is not sufficient for early diagnosis and screening. Then some other incidental findings can be found out, which can cause sometimes distress to the patient. That is another major issue that was faced in this trial. That is, the nodule would be some benign nodule or just an infectious nodule or a calcified lesion. But it causes that once we diagnose, once a lesion is seen in the cancer and in the CT scans or in the low-dose CT, and when we tell to the patient that there is some finding like this, so we need to investigate further or we need to follow up yearly, it causes so much of mental stress, anxiety, depression, and worry to the patients, and that itself could cause some other harm to the patient, like the patient goes into severe depression, goes into suicidal attempts, or goes into some other mental trauma. So that incidental finding, even though if it would not be cancerous, but still it causes a lot of attention to the patients. So that what was another harm of this screening using this low-dose CT. Then conventional CT scan is required for detailed evaluation if there is suspicion, which can cause more radiation exposure and radiation-induced injury also. So that was another issue. That was that is, yes, if a lesion was seen, so for more detailed study or for follow-up, or sometimes if more suspicion was there, contrast study was required. So that causes more radiation exposure. And in this National Lung Screening Trial, as I have explained, many people were put into more invasive procedures, and these procedures itself could cause some harm, like pneumothorax. That is that procedure related harms were caused to the patients, and sometimes because of that also patient can die or can become handicapped. So such more invasive procedures was causing harm to some patients, and also both physical and psychological stress was caused due to this early screening using low-dose CT. So these are some of the harms of early screening using low-dose CT. So both benefits and harms are there. Both should be explained to the patients properly before selecting them into the screening. Next slide, please. So there are some issues of implementation also. First of all, the cost. Sometimes every people might not be able to afford such screening trials, even though if they are smokers or they are willing to. So the cost was an issue. Then radiological techniques, that is more advanced radiological techniques are required for this early diagnosis. And then participation rates, even if the patient is eligible, sometimes all of them will not be ready to participate in the screening trials. Then selection criteria, that optimal smoking cessation, minimizing harms, then screen interval, all these were an issues. All these could be an issues of implementation of this early screening or using low-dose CT. But in a way, low-dose CT always it is considered to be effective, because always cancer can be diagnosed in an early stage, and also the death mortality, there is a reduction, significant reduction in mortality because of this early screening, even though such harms and issues are seen. Next slide, please. So I would like to conclude my talk saying that identification of the right population is of utmost importance. That is the correct selection of the criteria, that is which age group and which population is to be included in the screening is very important. Then always it is along with that, it is always it is important to reduce the false positivity rates also, that is creating unnecessary havoc and tension and psychological issues to the patient should also be avoided, because it is obviously when they come to know that they have some lesion in their lungs that could be cancer, it causes so much of issues to them. So always we have to try to minimize false positivity rate. It is important to counsel the patients that this is not cancer, it is just a screening trial. We will go into invasive procedures only if we suspect that it is cancer. Then choosing the least invasive approach is also very important. That is only if there is significant increase in the size, that is the doubling rate is there for all nodules, pulmonary nodules. So if there is significant increase in the size after this doubling time, then only post that patient to further investigations. Otherwise, try to avoid the invasive procedures because that can also cause harm to the patient psychologically and physically. So with this, I like to conclude my talk. Thank you so much.
Thank you, Arathi. Just taking us along regarding the screening. If we have questions, we can allow 1 or 2 questions, or we can put it in the chat box and we can do it at the end of the session. Himanshi?
So, sir, I'll request if we have any questions from the audience, I would request if you put it in the chat box, and ma'am can then just answer it on the chat box. Because of lack of time, we'll just move on to our next session.
Thank you. Next session is about when to operate and when not to operate. Only the masters like Dr. Mistry can suggest when not to operate. So I hand over to Dr. Mistry, who is a real, very congenial colleague and very easy to work. And I really enjoy talking to him every time when we chat. Dr. Mistry.
So good evening. Thank you, JP, for all the kind words. I reciprocate all the sentiments that you have expressed, and I would like to share my screen. Is that possible?
Yes, sir. Please go ahead, sir.
No, I think you will have to do it because the system is not allowing. You have the slide deck, no?
Yes, sir. We have the slide deck.
Yeah, I would suggest that you do it. Yeah.
Sure, sir. Sure, sir. Just share your slide.
Right. We can start the. So before we delve into the topic of when to operate and when not to operate in patients with lung cancer, let us go through certain facts which all of us know, but good to reiterate. One of the most common cancer, lung, is, as seen by these statistics, almost 2.2 million new cases are diagnosed annually. Not only that, but it is one of the most lethal type of cancer because it is responsible for greatest number of deaths across all cancer subtypes, amounting to almost 1.8 million deaths every year. And one of the reasons, actually there are 2 reasons why I think the lung cancer is so lethal. One is that majority of our patients present in very advanced stage, but the other would be the natural biology of lung cancer, which makes it difficult to treat, and the mortality is very high. Next slide, please. Just to show you what is the status in India, as you can see here, in stage 1 and 2, we only get about 5 to 6% of cases, and this was my experience at Tata Memorial Hospital. Here at KDH, we of course see more patients who are operable because of the reference bias. But if you look at all comers, then only about 5 to 6% of patients who walk into the OPD would present in stage 1 and 2, where surgery plays an important role. Majority of the patients are in stage 4, and where there is absolutely no role for any type of surgery. And stage 3 is about 30%, and I would suspect that about a third of these patients would require surgery after multimodality treatment. And this, the fact that it is advanced cancer is true for both genders, women as well as men. Next slide, please. Okay, now we all know that surgery is the standard of care in patients who have early stage lung cancer. However, anything more than that would require multimodality management. And in fact, many of the patients who are thought to be early stage would have node positivity or certain other adverse factor, following which they may require adjuvant treatment. So majority of the patients, I would say, with lung cancer require multimodality management. Next slide, please. So this is the TNM staging for lung cancer. And as can be seen here, patients who are in stage 1, which includes T1, T2, T3, early T3s, who have N0 or N1 status, they would fall into stage 1 and 2. And these are the candidates who go in for surgery upfront. The other patients who have either supraclavicular lymph nodes, contralateral mediastinal lymph nodes, or distant metastases are all patients who will not be candidates for surgery. And we have in between group, which is 3A and 3B, where surgery will play some role after induction therapy, and this is what we are going to discuss. Next slide, please. So what are the indications for surgery? So starting with early stage lung cancer, stage 1 and 2, where there is no controversy, patients go in for surgery upfront without any kind of induction. Then you have the locoregional cancer, stage 3A, and select stage 3B, where surgery will be part of the multimodality treatment, and when to operate is what I'm going to discuss subsequently. Then you have relatively advanced cancer where there is some role for surgery, such as patients who are T4, where they have ipsilateral in the ipsilateral lung, but in a different lobe or nodule, or patients who have nodule in the contralateral lung. And these patients, select patients who have N0 or N1 status, and where the PET scan and the MRI of the brain has ruled out any other site of disease, can be treated with curative intent as a part of multimodality treatment. Also, you have stage 4 cancers, M1B, where patients have localized disease or locoregional disease, and they have solitary brain met or adrenal met. And again, these subset of patients, not many, but these subset of patients can again be looked upon with treatment with curative intent, where surgery will play an important role again. And lately, with advancement in the medical treatment for stage 4 cancers, we now have areas where the disease has remained under control or responded completely at all sites except 1 or 2. And if that keeps progressing, then there is role for local treatment, for oligoprogressive disease at 1 or 2 sites. And in that, it could either be surgery or radiation therapy, depending on the site of oligoprogression and patient's general condition. Next slide, please. So these are the indications for surgery. Now, details of surgical management I will discuss under 4 headings, starting with staging of lung cancer, when do you operate, extent of surgery, and then surgical approach. Next slide, please. Coming to the staging, the story of lung cancer generally begins with a chest X-ray followed by a contrast-enhanced CT scan of the chest. Now, contrast-enhanced CT scan of the chest is good for T staging, also to some extent for metastatic disease. But when it comes to lymph node status, it is not very accurate because the only way to predict malignancy is the size, and that is not very sensitive. As it can be seen, the sensitivity of just a contrast-enhanced CT scan in staging the mediastinal lymph node is pretty low, 55% to 60%. So we have to go to the next stage of imaging, which is PET CT scan of the whole body. Again, this will give you good, the T stage as well as presence of asymptomatic distant metastasis when you are staging a patient with potentially early stage lung cancer. And the sensitivity of PET CT scan for mediastinal staging is reasonably high, but still not in the region where you can with confidence say that patient has stage 1 or 2 cancer without mediastinal lymph node. So we have to proceed to next slide, please. Either some form of invasive staging, it could be minimal invasive mediastinal staging using the technique of EBUS and EUS, or the conventional mediastinoscopy. Now here I've listed all the modalities for staging of the mediastinal lymph nodes, and as you can see, when it is non-invasive, just image-based, the sensitivity and specificity is not good enough. As we go into invasive staging, both sensitivity, specificity, and accuracy improves, but each one taken individually has some limitations. However, when you combine EBUS and EUS, then you get accuracy and sensitivity, which is reasonably good, based on which we can say with some amount of confidence that patient does not have, ipsilateral or contralateral mediastinal lymph nodes which are metastatic. Next slide, please. So the general algorithm that all of us follow, which is based on evidence, which is published, that patients who are diagnosed with lung cancer and who are potentially thought to be having localized disease and are heading for surgery, the first investigation would be a PET CT scan. If the PET CT scan shows that there is a small nodule which is peripheral without any activity in the mediastinum, these kind of patients can be taken up for surgery without further staging. However, all other patients would need EUS plus minus EBUS. And if after that also one is not very certain about the mediastinal staging because of say clinical factors or the size of the tumor, then you will have to do mediastinoscopy. Mediastinoscopy generally is part of the definitive treatment. So you start, patient is prepared for surgery, but you start off doing mediastinoscopy, and if the nodes turn out to be positive on frozen section, then of course you abandon surgery and patient goes in for induction therapy. But if the nodes are negative, then they proceed with, one can proceed with surgery. So it is part of the composite treatment methodology that is adopted. Next slide, please. Now we'll discuss a little bit about the brain scan. We all of us know that patients with lung cancer, either early or advanced stage, can have asymptomatic brain metastasis. Do we do brain scan for all patients? When I say brain scan, the preferred scanning method is MRI with contrast. But if there are any contraindications, then you can also do CT scan of the brain. So when we talk about imaging of the brain, we all know that stage 3 patients, will have a high incidence of silent brain metastasis to the tune of 21%. So if any of these stage 3 patient is being planned for surgery in future after induction therapy, they should have a preoperative or in fact pre-treatment MRI of the brain to rule out silent metastasis. When it is stage 1, the incidence of silent metastasis or asymptomatic brain mets is very low, 0 to 1%. So in these patients, one can do away with MRI. But and then stage 2 patients lie between stage 3 and stage 1. So in stage 2 patients, one has to use discretion, and one can do MRI of the brain if the histology is adenocarcinoma or if the patient is young. because these subgroup of patients are at higher risk of having brain metastasis. Next slide, please. Okay, now timing of surgery. So if the patient has been staged stage 1 or 2 after whatever we have discussed, these patients would go in for upfront surgery. There is no role for any kind of induction therapy. So this is very straightforward and there is no controversy in this. Of course, there is controversy in the sense whether it should be surgery or radiation therapy, and I'm sure Dr. JP would have something to say about it. Next slide, please. Now, as we come to higher stage locoregional disease, the topic which is almost always discussed is what do you do when patient presents with N2 lymphatic N2 stage N2. Now, we all know that N2 stage consists of a heterogeneous group of patients, starting with at the one end of the spectrum, you have patients who have single lymph node metastasis, which may be even microscopic, not seen on scans. Then you have single station involvement, multiple station involvement, and then you have the extreme where you have conglomerate of lymph nodes which are completely unresectable. So, it is difficult to decipher what to do with this group of patients because it is not one homogeneous group, it is a heterogeneous group. But next slide, please. So to get some guidance, we go through various guidelines which have been provided and published in the literature. I will be referring to 5 guidelines, BTS and SCTS and NICE guidelines from UK, American guidelines from, ACCP guidelines from the US, NCCN guidelines from the US, and then you have the ESMO guidelines for management of N2 disease. Next slide, please. Now, if you go through each of these guidelines, then how do you interpret the recommendations which have been made? All these guidelines acknowledge that N2 disease is heterogeneous and there is actually need for universal definition of different subgroups for interpretation of data and, what would happen to one subgroup of patient if a particular modality of treatment is or sequencing of modality is decided. So everybody admits that while N2 is heterogeneous, for proper planning, we should have a new system where each subgroup is defined and then we can have proper interpretation of the data. Everybody agrees that multimodality treatment is standard of care with chemotherapy for management of occult distant metastasis, occult distant disease, and surgery or radiation therapy or some form of combination for local control. 3 out of 5 guidelines recommend induction therapy prior to surgery. The other 2 have found that the difference between induction and adjuvant treatment, the difference is hardly significant, and therefore the sequencing could be anything, but the important thing is to give chemotherapy. However, all the guidelines again concur that significantly higher proportion of patients are able to complete the planned treatment when induction therapy is used as compared to when the treatment is in adjuvant setting. So generally the consensus today is that patients should receive induction therapy, either chemotherapy or chemoradiation therapy before undergoing surgery. Next slide, please. Now coming to this third aspect of management is the extent of surgery for a primary cancer. The standard of care for localized disease, is a lobectomy. This is the standard of care, and almost 90% plus patients who undergo surgery for lung cancer would go through lobectomy. Patients who have central disease or where the disease is crossing the fissure, to get an R0 resection, one will have to do pneumonectomy. A word of caution here, those patients who have received induction chemoradiation therapy, one should try and avoid pneumonectomy at any cost, because trials have shown that these patients, the post-op mortality is high and the benefit from surgery is not really there. The other 2 options which are now become available are segmentectomy and wedge resection. When do you do this? With the advent of screening, we are now, not in our country, but in Western countries and more so in Japan and China and Korea, they are picking up nodules which are even less than 1 centimeter. And doing lobectomy for these nodules will be like an overkill. And therefore, people prefer to do either segmentectomy or anatomical non-wedge resection, preferably segmentectomy. The other set of patients where segmentectomy or a non-anatomical wedge resection is performed is those who have localized disease, but the lung functions are fairly compromised and they can't even withstand lobectomy. So such patients are also, selected for undergoing wedge resection or segmentectomy. Next slide, please. Like any cancer, when it comes to surgery, we have surgery for the primary disease and we have surgery for the regional lymph nodes. When it comes to lung cancer, it is no different. So mediastinal lymph node dissection is necessary for evaluation of the nodes, but the extent of lymph node dissection which is necessary is actually uncertain. There are 4 randomized trials which have been published, and the meta-analysis of these trials show that patients who undergo systematic mediastinal lymph node dissections have actually small to moderate improvement in overall survival compared to patients who have undergone sampling. So today, most of the surgeons and most of the societies recommend a systematic lymph node dissection, and I don't see any reason to perform anything less than that, because morbidity of doing systematic lymph node dissection is no different from doing sampling. Next slide, please. The third, as the aspect regarding surgery as to how do you perform, we have 3 modalities now available. One is the conventional or the open thoracotomy approach, which is still practiced very often in our country because of the type of cancers which we see large tumors or lungs which are very adherent. But there are 2 minimal invasive ways in which you can perform the same surgery. The extent of surgery does not differ, both for primary as well as for the nodes. And the 2 the minimal invasive surgery forms are video-assisted thoracoscopic surgery, or what we call VATS. And more recently, since about a decade or so, we have now robotic-assisted thoracoscopic surgery. Now, the reason why most people today would prefer minimal invasive surgery is because the post-operative morbidity, even in randomized trial, has been shown to be much less compared to open surgery. So wherever it is feasible, wherever there is experience available, and if the patient has a tumor which is appropriate for minimal invasive surgery, he or she should undergo minimal invasive surgery. Next slide, please. So to summarize, indications for surgery in lung cancer are well defined. Stage 1 and 2 patients would go for upfront surgery. Stage 3 patients would undergo surgery after careful selection following some form of induction therapy, either chemotherapy or chemoradiation therapy. And surgery is also indicated in select patients with advanced cancer, again as a part of multimodality treatment. Next slide, please. Thank you very much for your attention.
Thank you, Dr. Mistry. It was an absolutely masterly presentation, taking up the flow, extent, etc. I think with this, if there are some questions, you can put it in the chat box. And thank you, both the speakers. And I hand over to our organizers.
Thank you, JP, and thank you, Dr. Advani.
Thank you so much, sir. We'll now move on to our next session. It gives me great pleasure to introduce our next chairperson, Dr. S.V.S.S. Prasad, who's a senior medical oncologist from Hyderabad. Welcome, sir. And I now request you to introduce our next 2 speakers.
Thank you, Kashish. And I now have to invite Dr. Subhash Ranjan, who is the screen is showing something else, Dr. Kashish? I mean, is it fine?
Sir, we've just interchanged the sessions.
Now, is Dr. Krishna Prasad going to speak?
Yes, sir.
Oh dear. Okay. Right then.
Actually, sir, I think Krishna sir is not there at the moment.
Okay.
I was told to.
Sorry. It is our mistake, sir. It's our mistake, sir. Sir, your session is next. So I apologize, sir. My mistake.
Right.
Himanshi, can you move to sir's session?
Okay. And so, who is going to speak now, Dr. Sanjo or Dr. Subhash?
No, myself, I have been told.
Oh, okay, sir. Okay, sir. So it's my pleasure to introduce Dr. Subhash Ranjan, who is a medical oncologist in Mumbai, practicing along with Dr. Advani, which I just came to know in the nice interaction that I had in the beginning of the session. And I invite him to take us through the updates on the ALK positive NSCLC. As we all know, we have moved from the Crizotinib to various other drugs with better action in CNS and so on and so forth. Dr. Subhash would be enlightening us on all that, and I request him to take over. Dr. Subhash, please.
Thank you very much, Chairperson, Dr. Prasad.
Yeah.
And with this, I see Dr. Advani sir also. So good evening to you, sir. And my talk on ALK positive NSCLC would briefly touch the milestones and its game changer, ALK TKI. And we know that approximately 5%, though it is mentioned here around 3.8, but in India, roughly 5% are ALK positive. Next, please. And we can identify them by FISH, ISC, RT-PCR, or NGS. Next, please. And once we looked into it, the history starts from 11th July 2007, when Manabu Soda et al. From University of Tokyo published this in Nature, where paracentric inversion was seen to produce EML4 ALK fusion protein finally. And this protein was the root cause of cell survival through PI3K, STAT3, RAS, PLC gamma pathways by giving very high energy frequencies to the downstream pathways. Next, please. And typically these adenocarcinomas, they are adenocarcinomas, and never smokers or light former smokers. You will find the population will be something like this. They tend to be younger, median age around 50 years, and ALK mutations and EGFR mutations are mutually exclusive. And these are the variants which have been seen when it is splits and joins with the paracentric inversion. Various variants of ALK4, ALK are found. So it is not that one particular subset is found. There are very many, and few have been shown here. Next, please. And when we start in the beginning, as Dr. Mistry said, stage 3 and beyond, when you see high probability that they might be harboring brain metastasis, and roughly 30% are found to have brain metastasis. Next, please. And this is the milestone I was about to touch in the beginning, when in 2007, EML4 ALK translocation discovery was made and was published. And subsequently, in 2012, Crizotinib first generation ALK inhibitor was approved, and thereafter, along with other ALK second generation inhibitors, in 2015, Brigatinib, Alectinib, Ceritinib, they were approved, and the second generation was finally taken up as a first line in 2017, and then came the third generation, Lorlatinib, and in 2021, US FDA approved Lorlatinib. Next, please. So when you come to the management part of ALK positive NSCLC, the prime modality of treatment is targeted therapy by ALK inhibitors. For some cases, the approach for cancers that requires urgent treatment prior to the results of genotype testing, pemetrexed platinum-based chemotherapy is the preferred one. And sometimes when you have failed on the combination of chemotherapy, monotherapy with immunotherapy, and all these things are effective. Next, please. Preferred options, as I told you, once you have to start for those who are newly diagnosed, next generation ALK inhibitor as first line treatment is preferred over Crizotinib. Now that could be second or that could be the third generation. In choosing between second generation inhibitors, suggest Alectinib, and I'll give you the reason, and very many reasons are, one of them is proof, the biggest proof, ALK trial. And then there is no direct comparison between second generation inhibitors. So it's difficult to say which one is the better one. But when it comes to starting the treatment, Brigatinib, Lorlatinib are the other accepted frontline options over and above. I'm talking about Alectinib and beyond. Next, please. So this was the waterfall plot, and in profile 1001, we had seen the activity and safety of Crizotinib, and very many patients, they had complete response, partial response, and stable disease. Some of them had progressive disease. Next, please. So profile 1014 trial, Crizotinib versus chemotherapy, we found ORR 74 versus 45%, and progression-free survival 10.9 versus 7 months. So definitely Crizotinib was superior to chemotherapy. Next, please. Then came ASCENT-4, and with ASCENT-4, we saw further improvement when Ceritinib, second generation TKI, was compared with the chemotherapy, and here progression-free survival 16.6 versus 8.1 months. So this was a major leap. Next, please. And when it came to Ceritinib, progression-free survival with and without brain metastasis, with brain metastasis, with Ceritinib, it was 10.7, and with chemotherapy, it was 6.7. And when there was no brain metastasis, it was almost 26 months, more than 2 years. And in chemotherapy arm, it was 8.3. Next, please. And when we go to the ASCENT-4 Asian patient subgroup, we found 34% reduction of progression or death, and hazard ratio was 0.66. So definitely here also in Asian subpatients, in subgroup analysis, we found the effect or impact of the TKIs. Next, please. Then came ASCENT-8, where we realized the Ceritinib dose 450 milligram per day is better than 600 or 750 because of the side effects and tolerability. And the result was equally good or maybe better. Next, please. So Ceritinib at a dose of 450 milligram per day with low fat meal showed numerically higher efficacy and less GI toxicity compared with a dose of 750 milligram per day in a fasted state in a treatment-naive Asian patients with ALK positive, advanced or metastatic NSCLC. Next, please. Then came the global ALK study, and we all know about it, that Alectinib 600 milligram twice a day versus Crizotinib 250 milligram twice a day till disease progression or unacceptable toxicity when withdrawal was done, or primary endpoint was taken as progression-free survival. Next, please. And here we could see that the hazard ratio was 0.50. Definitely Alectinib was superior to Crizotinib. And with this, when we looked at the cumulative incidence of CNS progression, the CNS progression in Crizotinib arm at 12 months was 41.4%, whereas in Alectinib, it was 9.4%. Next, please. And in Japanese ALK phase 3, we found almost same result. Definitely, the Alectinib was better than Crizotinib with PFS, which was not reached with Alectinib, and Crizotinib 10.2 months, and hazard ratio was 0.34. So it was less discontinued during treatment, and even adverse events were less than Crizotinib. There was no treatment-related mortality in both arms. Next, please. So over and above, now whenever you start with something, there is always something keeps on lingering in the mind of the patient as well as the doctor, that when the mutation may come up into the scenario. And there are very many of them which can be seen in this slide. There are a few which have been named here, but next, please. When you look at the mechanism of resistance, then you find there are almost 5 types of mechanisms, in which one is ATP binding domain mutation, in which the most common one fits in. Then comes non-ATP binding domain mutation, in which the other one, I'll tell you, the L1152R fits in. Then comes gene amplification, when tumor amplifies the genes to produce more protein and do maximum cell invasion, growth, and goes for survival. And the fourth is activation of bypassing signal pathways of EGFR, KRAS, KIT, etc. And fifth, very many things, they go into unknown mechanism. Next, please. When you see the swimmer plot in one of the Japanese studies, they found that finally mutation sets in, and that kind of mutation forces the physician, the oncologist, to change the treatment from one line to the second line and maybe the third line. And these are the points where biopsy has been carried out. And these are the mutations which were identified in that study. These are the medicines which were taken into account over and above when mutations were identified as second line or third line. So gray is chemotherapy, red is Alectinib, and blue is Crizotinib. So the sequence was followed something like that in various patients, and in very many chemotherapy was also considered. Next, please. And when they compiled the data, they found G1202R was the commonest, with Crizotinib, Alectinib, Ceritinib, whereas in Lorlatinib, L1196 and G1202 double mutation was found, which caused the resistance with Lorlatinib. Next, please. So secondary mutations in ALK-kinase domain, they cause resistance to first or second generation TKI. After failure of second generation TKI cancers, the ALK mutations are often responsive for further ALK inhibition to change over to the second line, third line, the generations I'm talking about. But they are more effective in where mutation has been identified than where mutation has not been picked up. And ALK G1202 confers resistance to first and second generation, whereas ALK L1196M and G1202R mutation, this combo, double mutant status, was found in Lorlatinib. So basically you see how Brigatinib goes into the notch and blocks the function of ALK protein. Here Brigatinib has gone in, and because of these hinges which impede the movement of the molecule TKI cannot dock in to the protein, and that leads to resistance. Next, please. And when it comes to Brigatinib versus Crizotinib trial in ALTA 1, that is when the first line trial was considered along with Brigatinib versus Crizotinib, then 12 months progression-free survival rate. These graphs are very small. I couldn't make it big, so you have to bear with me. And the progression-free survival rate was 67 versus 43. 67 versus 43 in Brigatinib versus Crizotinib, and hazard ratio was 0.49. So when you go to the forest plot, you find that everything was favoring Brigatinib than Crizotinib. And when it came to duration of response, again, the Brigatinib took the lead over Crizotinib. So the second generation is better than first generation TKI. Next, please. And when it came to Ensartinib-eXalt3 trial, had shown again the advantage of 25.8 months, almost 26 versus 13 months with Crizotinib. Next, please. So I would request you to press it again, please. So Lorlatinib, this is the TKI protein, and ALK, I'm talking about the fusion protein, and these are the resistance mechanism. And when it comes to Lorlatinib, obviously the dual one comes and sets in, and that was the time Lorlatinib was taken into account to cope up with the resistance found during second generation therapy and metastatic brain disease when was seen progressing. Next, please. And then Crizotinib structure was seen open and wide. Next, please. And Lorlatinib was seen in a very peculiar shape of roundel, and this had the advantage for, next please, entering into the CNS, crossing blood-brain barrier and entering into the target areas, and binds with high affinity to most of the ALK resistance mutations other than the dual combo. Next, please. So Crown trial came where Lorlatinib was compared with Crizotinib. Next, please. And here Lorlatinib 100 milligram daily was given along with Crizotinib in 1:1 random, and 250 milligram BD Crizotinib was given in the other arm. And once these patients, they received, obviously primary endpoint was PFS by BICR. Next, please. And we saw at 24 months, the PFS percentage was 68.2, whereas the latest data has come of 36 months. It is 63.5. Whereas in Crizotinib arm, the data says at 24 months, 2 years, 21.5%, and at 3 years, it has come to almost 19%. So this is something which is very, very encouraging. Next, please. And when you look at patients with the baseline brain metastasis, we see there is definite advantage of Lorlatinib over Crizotinib arm. And the 36-month data again shows patients without baseline brain metastasis, Lorlatinib and Crizotinib, there's a wide gap. It encourages us to focus on Lorlatinib-based management when feasible. Next, please. So when you come to NCCN guidelines, we say when ALK rearrangement protein is detected, then if you have to start with the first line systemic therapy, which is Alectinib category 1, Brigatinib category 1, Lorlatinib category 1, and other recommended Ceritinib category 1, and useful in certain circumstances, Crizotinib is old molecule, but category 1 only in certain circumstances we all know for what. Many times because of financial constraints, and many times because of other reasons, non-availability or XY. So, and when we see, say for example, patient has been started on chemotherapy, so it is better we complete the chemotherapy and start with the ALK TKI in the same fashion as first line therapy has been given with the second generation, and last is the first generation in the order of preference. Next, please. So if there is progression on second generation and if it is asymptomatic, then it is better we look after it by radiotherapy or surgery and continue with the same medicine which was started for the patient. And say, for example, patient is symptomatic, in that situation, a definite therapy is required. And after that, we will go ahead with the TKI in the same order. But if it is systemic and limited, then we will go for SA, BR or surgery, and we may change to Lorlatinib if you pick up a resistance where ALK G1202R is directed. And in multiple lesions, you can go ahead with chemotherapy if required, along with immunotherapy or maybe anti-VEGF therapy. Next, please. So if anybody who was on Crizotinib, asymptomatic, and something has progressed, then go ahead with the local therapy. And if it is systemic progression into the brain, if it is in the brain, obviously it is local therapy. And if it is systemic, then limited metastasis, one oligometastasis, I mean, then you go for SVRT. Otherwise, you go for systemic therapy. And in systemic therapy, you all know you can go ahead with chemotherapy. Next, please. And Empower trial has shown that there was definite advantage of incorporating atezolizumab over and above anti-VEGF and along with chemotherapy. And we can see 19.2 versus 14.7 months with this kind of overall survival advantage which was observed. So it is good to incorporate immunotherapy along with. Next, please. Skip, please. So if we come to the last slide, I would say go ahead with Alectinib, Brigatinib. In case mutation has been detected, go ahead with Lorlatinib, or disease is progressing, go ahead with Lorlatinib. And if a person was on Crizotinib, then go for second generation, and in disease progressing, then go for Lorlatinib. And if over and above things are progressing, then platinum-based chemotherapy, atezolizumab, bevacizumab, or monochemotherapy and ONCOGENIC. These are the pattern in which one can follow in your own environment. Next, please. Then I found this interesting article that resensitization to Crizotinib by Lorlatinib in ALK resistance mutation when L1198F was found. So it has been observed, but yet it has to be proven by virtue of more and more such people undergoing trial. Next, please. Then a word about cancer vaccine against ALK rearranged lung tumors. A lot of work has been done in various centers in Boston, in various locations in the United States, even in China, Japan. All these places I have seen work is going on, and the day is not far when you will have vaccine to be incorporated along with the main treatment lines. Next, please. Next, please. So maybe this was my last slide. And with this, I end my talk and I leave it to my chairperson, sir, for anything which you want me to clarify.
That was a nice presentation, Dr. Subhash, and you have covered all the spectrum of ALK positive tumors. And of course, as we all know, Alectinib forms the first line, and then possibly Lorlatinib comes second if we have the lineup. And if there are any questions that we put up in the chat box, Dr. Subhash can answer. In the interest of time, we'll move on to the next presentation, which is by Dr. Sanjo Varghese. He's a medical oncologist in Kerala. He will be talking on the significance of maintenance treatment post-CTRT in unresectable stage NSCLC. Dr. Sanjo, please.
Yeah, good evening, everyone. Myself, Dr. Sanjo, consultant medical oncologist from Smitha Memorial Hospital. So I'll be talking on the significance of maintenance therapy post-concurrent chemoradiation and unresectable stage 3 non-small cell cancer. So as we all know, concurrent chemoradiation is the standard of care in patients who have locally advanced stage 3 unresectable non-small cell cancer. So we have data comparing and contrasting the sequential and concurrent chemoradiation, wherein which the concurrent chemoradiation is significantly better with respect to the overall survival and progression-free survival. So the overall survival at the 5 years comes up to around 15.1% in concurrent chemoradiation arm, but at 10.6% in the sequential arm. So, but this comes with a price tag of increased toxicity. Next slide, please. Again, the same depiction. Concurrent chemoradiation is significantly better than sequential chemoradiation with respect to the survival and progression-free survival. Next slide, please. So, in the current guidelines, in which the chemotherapy regimens which we use along with the radiation are platinum-based chemotherapy, cisplatin etoposide, the most commonly used, and cisplatin vinblastine, pemetrexate carboplatin, and cisplatin, and paclitaxel carboplatin. So post-concurrent chemoradiation, if the patient has got a complete remission or partial response or at least a stable disease, so if there is no progression, we go for a consolidation treatment. Next slide. So many patients with post-concurrent chemoradiation, they suffer from anxiety and distress, especially when there is not enough good response with the concurrent chemoradiation. And during surveillance, we may see many of the adverse events of chemoradiation, which includes changes in pulmonary function, especially radiation pneumonitis, and in the form of dyspnea and neuropathy secondary to taxanes. So patient may experience depression as well, and which some patients cite as the most distressing effect of radiation. Next slide. So here the role of consolidation. Next slide. So we have tried with some consolidation chemotherapy in the form of various trials have seen the effect of consolidation chemotherapy with docetaxel in combination with cisplatin, and targeted therapies like Gefitinib, cetuximab, we have tried not without much good results. Next slide. So there, over the past 10 years, there have been no significant advance in the treatment of unresectable, locally advanced non-small cell cancer following concurrent chemoradiation. So pooled analysis of 41 phase 2 or phase 3 studies indicated that there is no significant improvement with any of the consolidation strategy. So either by using the same drugs which you are used as an induction, or by switching the chemotherapy agents, or even if you add a newer molecule like Gefitinib or cetuximab, there is not much of a significant benefit. So regardless of all these drugs used, the 3-year survival rates come up to only 15 to 25%. Next slide. So currently there is an unmet need in the consolidation of concurrent chemoradiation. So again, concurrent chemoradiation is superior to sequential chemoradiation, but it comes with a higher grade 3 toxicities. And there is again higher recurrence rates after concurrent chemoradiation, which results in poor prognosis. So the 5-year survival rates, even after using the doublet chemotherapy, is only 15%. And there are no approved maintenance therapy following concurrent chemoradiation. Next slide. Next slide. So here we come across the rationale of using a PD-L1 inhibitor as a consolidation agent. So from the preclinical studies, we find that chemoradiation has direct cytotoxic effects, which can induce certain immunomodulatory changes. So this will secrete cytokines, upregulates the PD-L1, then upregulate other immunogenic markers, and it will induce the immunogenic cell death and antigen release. Next slide. So with this background, we have tried Durvalumab, which is a PD-L1 inhibitor. So it blocks the PD-1 mediated inhibitory signaling and thereby enhances the effector T cell function and tumor cell killing. So this will maintain the effector function within the tumor microenvironment. Next slide. So in the phase 3 randomized double-blinded PACIFIC study, so we have recruited patients with stage 3 locally advanced unresectable non-small cell cancer who have not progressed following definitive concurrent chemoradiation. So 18 or above with a performance status of score 0 or 1 and who is expected to have a life expectancy of more than 12 weeks. So such patients were recruited within the next 6 weeks post concurrent chemoradiation, randomized into 2:1 ratio to Durvalumab 10 mg per kg every 2 weeks for a duration of total of 1 year. And the primary endpoints were PFS and OS, and the secondary endpoints were overall response rates and the duration of response, the safety, and others. Next slide. So here they have the PACIFIC study. The randomization was up till 6 weeks after concurrent chemoradiation. Next slide. So with respect to the baseline patient characteristics, it was matched well with respect to age, sex, race, disease stage, comprising stage 3A, 3B, and 3C, performance status. And there were a few patients who are EGFR positive patients. 6% were EGFR positive. Next slide. Importantly, the PD-L1 expression, around 40% of the patient did, it was unknown. The PD-L1 expression was unknown, and only another 40% of PD-L1 was less than 25%, and only 24% had a PD-L1 expression level of about 25. And the other randomization, the other stratification characteristics based upon was smoker and non-smoker status. And 25% of the patients were given some form of induction chemotherapy. And all those patients who had a progression after concurrent chemoradiation were excluded, and the other responders were randomized. Next slide. So overall, there were 711 patients, out of which 191 patients have received some form of induction chemotherapy prior to the study start. Next slide. Next slide. Yeah, and the updated 5-year OS data. So we can see that the curves were separating wide enough from the beginning. And by the end of 5 years, 60 months, the 5-year OS was 42.9%, whereas in the placebo arm it was 33.4%, with a hazard of 0.72. Next slide. So it is the first and only approved IO to demonstrate an OS of 43% by the end of 5 years. Next slide. And coming to the PFS also, it was started separating from the initial time. And by the end of 5 years, the 5-year PFS was 33% in the Durvalumab arm and 19% in the placebo arm, with a hazard of 0.55. Next slide. So again, this is the first and only approved IO to have a sustained and a durable PFS of 33% at the end of 5 years. Next slide. And following the discontinuation of Durvalumab, the first subsequent therapy, so again, around 16% has received platinum doublet chemotherapy, and around 10% has received single agent chemotherapy, and for only around 4% went on to receive further immunotherapy, and 4% has received targeted therapy. So overall, 40% were given subsequent therapy in the Durvalumab arm, and 54% received subsequent therapy in the placebo arm. Next slide. Pattern of progression. So we could find that the intrathoracic progression was significantly less compared to the placebo arm, both the intrathoracic and the extrathoracic as well. So significantly, the brain mets were significantly less in the Durvalumab arm. Next slide. Next slide. Next slide. And coming to the safety profile, so Durvalumab are reasonably well tolerated. Grade 3-4 adverse events were found in 30% of the patient, as contrast to 26% in the placebo arm. So serious side effects which led to the discontinuation was 15% in the Durvalumab arm, as well as when compared to 10% in the placebo arm. So importantly, pneumonitis, which you can find after radiation as well as a part of immune-related adverse event. Pneumonitis was found in 34% in the Durvalumab arm, but 25% in the placebo arm. So in 6% it led to the discontinuation in the Durvalumab arm, whereas it was 4% in the placebo arm. Next slide. Next slide. So to conclude, so locally advanced non-small cell cancer constitutes a heterogeneous population. The 5-year OS was only 50.
Yes, sir. Can you hear us? So you'll have to unmute your mics.
Yeah, so it was 5-year OS was only 15% with concurrent chemoradiation, which was the then standard of care. And then we had Durvalumab, which has from 15%, it has increased up to 42%. The 5-year OS now we have, it's a good amount of 42%. So Durvalumab has considerably increased the survival in stage 3 unresectable non-small cell cancer after concurrent chemoradiation. Thank you.
Thank you so much, sir.
Yeah, thank you, Dr. Sanjo, for that nice presentation. Again, any questions that would pop up would be put in the chat box and you can go through them. And I would now hand over the proceedings to Dr. Subramanian, who would be the next chairperson for the upcoming session.
Sir, unfortunately, Dr. Subramanian will not be able to join us. So can I request you to introduce our next speaker?
We'll then ask Dr. Krishna Prasad, from medical oncologist from Bangalore, to talk on experience sharing on Durvalumab in extended stage small cell lung cancer.
Thank you, sir.
Yep.
Am I visible and audible?
Yes, yes, yes.
Thank you, sir.
Right.
So just make it full screen.
Yeah.
Yeah, I thank the organizers for this opportunity. So I'll be speaking on extensive stage small cell lung cancer. So let's dive deep into this patient. He's a 35-year-old gentleman seen in June 2021, presented initially with hoarseness of voice, which slowly progressed to aphonia. No significant comorbidities. He enjoyed smoking. He visited the ENT surgeon, who diagnosed it as left vocal cord palsy and suggested a CT chest. As happens in many instances, they try their own remedy, and it went on till August 2021 when he did the CT scan. There was a small soft tissue lesion in the left apex and multiple lymph nodes in the mediastinum and hilum, which were obviously pressing on his recurrent laryngeal nerve, causing vocal cord palsy. Somebody saw him and said, this looks like tuberculosis, and he was started on ATT. Cough worsened. In fact, he had an episode of seizures and was started on anti-epileptic drugs. CT chest was done. Now, CT chest was done in October 2021. So from June to October, 4 months we have lost in him. So in October 2021, there was a large lesion in the left upper lobe with mediastinal extension and encasement of the pulmonary artery. Mediastinal lymph nodes were multiple and he had some post-obstructive consolidation. So you can see this lesion here, predominantly nodal mass. So this PET scan showed mainly nodal mass with the left supraclavicular node also you can see. So this patient also had a brain metastasis in the right parietal lesion. The MRI brain done on 29th October showed a 2 centimeter lesion in the right temporal lobe with mild surrounding edema. There were also multiple subcentimeter lesions which you cannot see now. So the biopsy from the lymph node showed small cell neuroendocrine carcinoma. PDL1 was positive at 3 to 4% TPS. So the final diagnosis in this patient was extensive stage small cell lung cancer with brain metastasis. So in these patients who have got small cell lung cancer, extensive stage with brain metastasis, the options probably are to give brain radiation followed by systemic therapy or start with systemic therapy. If you're starting systemic therapy, we always need to consider whether it is chemotherapy alone or a combination of chemotherapy with immunotherapy. So after a lot of deliberations, now there are quite a significant recommendation like this one from the multidisciplinary panel of European experts, which suggested that patients with symptomatic brain met should get radiation followed by chemotherapy. Similar guidelines in the NCCN, which says that extensive stage disease with brain metastasis, if they are symptomatic of brain mets, it is better to radiate the brain before you start systemic therapy. So patient was started on radiation in November, 30 gray, 10 fractions to the whole brain with hippocampal sparing, followed by 9 gray in 3 fractions to the gross lesions. Once they finished the radiation, they were referred back to us for systemic therapy. And as the NCCN guideline says, the preferred regimen is a combination of carboplatin or cisplatin with etoposide and an immuno-oncological drug. So patient was started on cisplatin, etoposide and durva on 22nd December. Now, what is the rationale of combining chemotherapy with immunotherapy in small cell lung cancer? Basically, we know that when chemotherapy is given, there is tumor cell killing. This induces neoantigen release and exposure to the immune system. So it's basically exposing the immune system to new antigens. Unfortunately, in many cancers, because of PD-L1 overexpression, there is evasion of the immune cell and T cell inhibition occurs. Now, when PD-L1 inhibitor is given or PD-1 inhibitor is given, this partially restores the tumor-specific T cell immunity, and this results in systematic, deeper and durable anti-tumor response of our immune system. So why this combination was given? This is based on the Caspian trial, which is probably one of the largest trial. It had 800 newly diagnosed extensive stage small cell lung cancer patients. Patients were randomized to either a standard chemotherapy combination of cisplatin or carboplatin 4 to 6 cycles, or an arm where initially there was an induction phase of Imfinzi plus cisplatin etoposide for 4 cycles, followed by maintenance Imfinzi until progression. The primary endpoint was overall survival. The key secondary endpoints, overall survival at 18 months, PFS at 6 and 12 months, overall response rate, and of course, quality of life. Now, the Caspian study crucially allowed for investigators' choice of cisplatin or carboplatin. It also allowed for patients with symptomatic or treated brain metastasis. And the arm, which is the control arm, allowed 2 things. Instead of only 4 cycles, it allowed 6 cycles of chemotherapy, and also it allowed prophylactic cranial irradiation. Now, how is it different from the IM Power trial? In the IM Power trial, PCI was also allowed in the experimental arm, whereas in Caspian, it was not included. Also, in the IM power arm, only 4 cycles of chemotherapy was allowed. So with this combination of allowing PCI and giving up to 6 cycles of chemotherapy, the control arm is much more reflective of real world practice and much more robust control arm. Also, cisplatin was not allowed in the IM power arm. So what is this Caspian study results? The overall survival, which was the primary endpoint, had significant benefit. You can see that at the end of 3 years, the number of patients who are alive because of infancy and cisplatin or carboplatin etoposide combination was 3 times more compared to those not receiving the immuno-oncological drug. And there is a clear separation of the two curves roughly occurring around 2.5 years. And there seems to be maintaining of that, and the gap between them remains, suggesting that this benefit seems to be a long-term benefit. So what about patients like our patient who had brain metastasis? Is the benefit as good as those patients without brain metastasis? Answer is yes. You can clearly say that the hazard ratio of somebody with brain metastasis is 0.69, and the hazard ratio of somebody without brain metastasis is 0.74, suggesting that Durvalumab is a good drug for patients with brain metastasis. Now, if you take many subgroups, whether it be cisplatin or carboplatin, younger age or overage, former or active smoker, and patients with brain metastasis, in every single subgroup, Durvalumab had an excellent outcome. What about progression-free survival? Even though there was no difference in the median progression-free survival, at the end of 12 months, the patients on Durvalumab were 3 times more likely to survive, and at 24 months, nearly 4 times more likely to survive than patients who have not received Durvalumab. And around 10% of the patients are continuing on Durvalumab even at the end of 3 years and are showing very good progression-free survival. Also, in terms of response rate, there is a significant 10% improvement when you compare patients who have received only placebo compared with immuno-oncology drug with chemotherapy. And at the end of 24 months, the response rate difference is still 3 times when you take patients with Durva plus chemotherapy. So our patient underwent radiation and has completed 4 cycles of chemotherapy and 6 cycles of immunotherapy. And there is a decrease in the brain lesion as well as in the lung and mediastinal nodes. You can see that there is significant improvement in all areas. So Durvalumab is a very interesting drug that it allows you to give it once in 3 weeks when you're giving chemotherapy. And then during maintenance, you can only give it once in 4 weeks. This makes it very easier for the patient to take this treatment rather than come in between for different drugs. So to conclude, Durvalumab plus chemotherapy is the standard of care in patients with first-line treatment of extensive stage small cell lung cancer. It shows sustained improvement in overall survival, and it compares with a very robust control arm, which is reflective of real world scenario. That means it allows 6 cycles of chemo, use of PCI, and use of any of the platinum agent. Benefit with Durva plus chemotherapy is observed across all subgroups, including patients with brain metastasis. Significant number, that is nearly 20% of patients are surviving even after 3 years. So excellent PFS benefit. Response rate is very good. It is convenient to dose and safety is excellent. With that, I thank you for this opportunity. Thank you.
Thank you, Dr. Krishna Prasad, for that excellent presentation. And I think we have come to the end of today's talks. I would now hand over the proceedings to Dr. S.H. Advani for his concluding remarks. Dr. Advani, sir.
Yeah, good evening, colleagues. I'm really thankful to all of you who have so nicely presented the data and enlightened us about this subject on the lung cancer. This is a cancer where rapid changes are occurring, and it's good to listen to all these talks, which thereby within 1 hour, you can update your knowledge and information. Also, thanks to Estra for giving us this opportunity to come together and exchange the information and knowledge. With this, I would like to thank all the speakers, panelists, and all of you for taking your time out to participate in this webinar. Thank you very much.
Thank you, sir.
Good night, sir.